Hey MidMind family, welcome back to Lecture 2 on our Vasculitis Series. If you missed Lecture 1, go check it out. We covered the big picture. Today, we're going to discuss two of the most important large vessel vasculitis you must recognize clinically, Giant Cell Arteritis and Takayasu Arteritis. Both are granulomatous vasculitis, but they affect different age groups, different vessels, and present with different clinical clues. By the end of this video, you will spot these on exams, in clinic, and save a patient's vision or limbs. Let's dive in. Let's begin with Giant Cell Arteritis, GCA. I want you to first look at these images. These images show you exactly how the temporal artery looks when affected: enlarged, tender, and inflamed. GCA is a granulomatous vasculitis affecting medium and large arteries. The classic vessels are the temporal artery and the branches of carotid artery, and it almost always occurs in people above 50 years of age. Pathologically, there is inflammation of the arterial wall, destruction of muscle and elastic fibers, and formation of multinucleated Giant cells. This leads to intimal hyperplasia and luminal narrowing, causing ischemia. Now, what does the patient tell you? Classic tetrad. The first, headache over the temple, new and worse at night. The second, jaw claudication, pain when chewing stick or gum. Third, visual symptoms, amaurosis vagus or sudden blindness. Fourth, BMR symptoms, shoulder and hip stiffness, flu-like fever. You must think of GCA immediately. And visual symptoms are the most dangerous because it's untreated. GCA can cause irreversible blindness. ECR and CRB sky high, over 50 and often over 100. But normal ESR doesn't rule it out. What's the diagnosis? The gold standard is temporal artery biopsy. What do you see? Giant cells, wall inflammation, and skip lesions. But negative biopsy doesn't equal no GCA. How? GCA causes skip lesions. They are patchy inflammation along the artery. A biopsy may sample an unaffected segment, missing the disease entirely. We can use ultrasound for the diagnosis and large vessel imaging if we suspect aortic involvement. Complication and treatment. Blindness is the number one fear from anterior ischemic optic neuropathy. It's irreversible in 24 to 48 hours. So, what do we do? Rule number 1, start steroids now. We start high dose of corticosteroids immediately, even before biopsy results. We can't wait. And in resistant cases, now we use interleukin 6 inhibitors. Now let's move to Takayasu Arteritis. Look at these images first. These show you the involvement of the aorta and its major branches. TAK is also a granulomatous vasculitis, but unlike GCA, it affects the aorta, the subclavian arteries, carotid arteries, and their major branches. And it occurs mostly in young women under 50, especially of Asian descent. Disease evolution includes stages. First, active inflammatory phase, then chronic fibrotic stenotic phase, and healing or classified phase. The classic presentation includes weak or absent pulses. That's why we call it pulseless disease. Difference in blood pressure between arms, cold, blue hands, arm claudication, pain when using the arm, possible neurologic or visual symptoms due to reduced blood flow to head and upper organs, early systemic symptoms like fever, fatigue, and weight loss, and the labs elevated ESR and CRB in most patients. Diagnosis depends mainly on imaging, angiograph, MR angiograph, and Doppler ultrasound. Biopsy is almost never done, unlike GCA, because the vessels are too deep. Classification systems exist to describe which segments of the aorta are involved. Because TAK affects major arteries, complications include severe stenosis, occlusion, aneurysms, secondary hypertension, especially renal artery involvement, heart failure, or stroke. Treatment of TAK includes high dose of corticosteroids followed by immunosuppressive DMARDs and sometimes biologics targeting interleukin 6 or tumor necrosis factor alpha. And some patients require endovascular or surgical interventions such as angioplasty or stent placement. Alright, mid-minders, that's a wrap on Lecture 2, Giant Cell Arteritis and Takayasu Arteritis. Let me hit you with your mid-minder mantra. Say it out loud with me. GCA above 50, headache, jaw pain, vision threat, and start steroids now. Save the site. While TAK in young women, no pulse, BB gap between arms, image the aorta, and suppress long term. Spot it fast, treat it faster, and save lives. Now go ahead, drop a brain emoji in the comments if you're locked in. Tag your study buddy and let's keep crushing it. Next up in Lecture 3, we'll discuss medium vessel mayhem with BAN and Kawasaki. Bell on, subscribe, I'll see you there. Stay brilliant, mid-minders.